Nice word. It's a pleasure for me to be here in Argentina, in the city that gave us our new queen. So, and I'm also very honored that you, despite the beautiful weather and this beautiful city, still want something to learn about immunogenicity. I hope I can tell you some things. So why should I talk about immunogenicity? Basically, I'm a rheumatologist. I do not much work in lupus, but I think the concept of immunology is also a concept that is very, that could be used in every clinician, for every clinician that uses biologicals, because it's a general principle. And so it's also a principle that will be useful for patients treated with biologicals in lupus. So where does my story start? It starts, I was trained as an immunologist in a laboratory, in the laboratory of Lucien Aarden, who, as you might know, developed the Critidia assay, that is the hallmark of the lupus serology. So I became a rheumatologist, and around the year of 2000, miracles happened, the revolution started. Because suddenly patients that had had active disease for many, many years could suddenly be cured, treated. And I was part of that miracle. So I saw many patients that suddenly could stand up and walk away. However, as often happens with miracles, sometimes these miracles disappear. So it also occurred in some of our patients. A young woman, 24 years old, very active RA, many joints disrupted, and then suddenly infliximab came, and infliximab made her able to live a normal life again. However, after a half year of treatment, suddenly the miracle stopped. It disappeared. And again, she was admitted at the hospital with a very active disease. And so then the discussion started, what is it? Why is it that we treat somebody with anti-TNF and the treatment doesn't work? Is it something specific for the treatment or not? What should we do next? And some clinicians, some rheumatologists said, well, we tried anti-TNF, now we must do something else. Basically, they said what is in the NICE criteria still nowadays. You do one anti-TNF, and if it doesn't work, you do something else. But we started the discussion, well, is this correct? Can we know something more? And so I went with this question back to Lucien Aarden, who was my mentor in the lab. And we discussed the problem. And we said, well, what are the possibilities? What are the possibilities if somebody fails anti-TNF treatment in rheumatoid arthritis? And we said there are two possibilities. Either the disease is independent of TNF, so driven by other pathways, other mechanisms, or we have not blocked TNF completely. So we decided to study this. And how do you study this? Well, you can have a wonderful lab and do the most interesting things, but if you don't have patients, if you don't have clinical material, you don't do anything. So what we did, we started a registry. And in this registry, we put every patient on a biologic in the Amsterdam area. And how do we do this? Well, we make it easy for the physicians. If they send their patients to our cohort that has a standardized follow-up, they don't have to fill in any paperwork. And if they don't send the patient into a registry, they have to do all the paperwork themselves. And this works really fine, so it means that all the physicians now send in their patients into our registry. And we have standardized a follow-up of almost 2,000 patients on biologicals of many diseases. And in this follow-up, in this registry, there is a standardized assessment of the disease activity score. For RA, we use the DAS28, which was not developed for this purpose, so it's not perfect, but it's standardized. And because it's standardized, it works. And then we started. And the first thing we wanted to know was if we have patients treated with anti-TNF, infliximab in this case, is the drug in the patient as we expect it to be? And for this purpose, we wanted to measure the drug itself in the patient. However, at that time, and I think still nowadays in many countries, it was not possible to measure the drug. So we had to make our own assay. But as I told you, we have a very experienced immunology lab, so it was not too difficult to make an assay to measure anti-TNF. Basically, we present TNF itself on an ELISA plate, we add serum to it, and if then the drug binds to TNF, so it has to be functional, we can detect it with another antibody. And the system works really fine for all the anti-TNFs, except for certolizumab. But for this, we have another assay. So now we can measure all drug levels of all the anti-TNFs, and similar also for other biologicals. And when we did this, we did remarkable observations. When we compared a group of clinical responders and non-responders of patients with ankylosing spondylitis, the levels in general were lower in non-responders. But more remarkable was the variation in drug level. So some patients had really high levels of the drug, and others had very low level, or not even measurable at all with our very sensitive assays, indicating a couple of things. It indicates that there was an association of clinical non-response and not having any drug level. And it indicated a lot of variation in the pharmacokinetics. It indicated that there might be different types of non-response, because you can imagine that patients who do not have the drug in their system are a different type of non-responder than patients who have high levels of the drug in the system. But clinically, we see them as one. We see them as non-responder. But the mechanism behind it might be different. So what could cause this variation in pharmacokinetics? What was the reason? And for this, we did another clinical observation. We did the observation of an infusion reaction in our cohort in two patients at week 14, after the induction scheme of infliximab, over here. And what we saw was that at the time point of the infusion reaction, there was no drug level measurable. And even at week 6, so before the infusion reaction, drug levels were markedly lower, significantly lower than in the whole group, indicating that an enhanced clearance of the drug was associated with something immunological, with an infusion reaction. So we said, well, this must be easy. This means probably that these patients make antibodies against the chimeric infliximab, and that these antibodies cause the infusion reaction, but also neutralize the drug. So we said we must measure anti-drug antibodies. However, at that time, same issue, same problem. There were no drug levels, there were no assays available for measuring anti-drug antibodies, only within the companies, but certainly not in the academic community. I think even in London, the group of Maney did not measure the anti-drug antibodies themselves, but had to send the samples to the company. And at that time, I think around 10 years ago, if you wrote in many papers, it was said that immunogenicity, well, that they looked at it without telling you what they did or how they did or when they did it, but they told us just, well, it's not important. And we said this can't be true. This is not the truth. So we must look for ourselves whether or not anti-drug antibodies are clinically relevant. Saying this, it was not so easy, because anti-drug antibodies, there are no standards. There are different types of assays, and each assay has its own difficulties, which is the same for lupus. We had a lot of experience, criteria. FAR assay. And there's this typical thing of drug interference, meaning that you have a lot of antigen in the circulation while you're trying to measure the antibodies. Basically, you could see this also as a model for lupus, for those immunologists interested in lupus, because it's about immune complexes. And measuring antibodies in the presence of the antigen also for lupus, of course, is interesting. We started straightforward by creating our own assays, and it took us 2 years, almost 2 years. And then in the end, after 2 years, I was excited, and I said to Lucien, well, I think we see something. And he looked at me and he said, no, you don't see anything. The only thing you see is noise. Because in our traditional assay formats, using ELISA systems, we had too much background problems. Antibodies binding to antibodies. And in the end, we could not say a real thing. And we almost wanted to stop, but then we twisted around the assay. So we used a different kind of assay format. And then we used an assay format that came from allergy. Basically, we used protein A coupled to cephorose, and we used this to bind the antibodies from the patient's serum, IgG1, IgG4, and then we add a label, the treatment, the therapeutic drug, but then iodined. Not the whole antibody in this case, because it will also bind to protein A, but a Fab2 fragment of it, iodine labeled. And this assay works really nice. Then you have low background, and we could measure high titers of anti-drug antibodies that were associated with clinical events. Only thing you have to know is that we use, in this case, Fab2 fragments, and in Fab2 fragments, a new epitope is exposed, anti-Hinge antibodies. So you will have some signal in many of your patients, because these anti-Hinge antibodies are very frequent in RA, but by competing with them with unlabeled pepsin-treated IVIG, the assay works fine. So now we had a really nice assay to measure antibodies against the drug. And this assay works well. It works also within the presence of a certain little bit amount of drug, but it's also drug sensitive. It also is competed by the drug itself. So in patients under treatment, you will only measure the antibodies that are in excess of the drug given. Which clinically might be the most important antibodies, but from research perspective or immunological perspective, you also want to know the patients that make antibodies in an amount that is less than the drug is given to patients. And for this, we modified our assay. We did an acid step, and this acid step disrupts the immune complexes. And after this dissociation, we added a Fab fragment of a rabbit to block the anti-TNF antibody, and it sets free the anti-drug antibody. So now we have a system that also can measure anti-drug antibodies in the presence of the drug. So we now had various assays to measure anti-drug antibodies. And we could find clinical relationships. However, people asked us questions, and they said, well, you measure antibodies, but I don't believe you. Or it's not true, or it cannot be true. And they said, you must show that these antibodies are neutralizing. And we said, it's not important, because what important is the pharmacokinetics. These antibodies are associated with clearance of the active drug. And what matters is the amount of active drug you still have present in the circulation. And if you have so much antibody that the drug is gone, you will have a problem with efficacy. But people kept asking these questions. And moreover, we also wanted to know, well, what exactly do these antibodies that patients make against therapeutic antibodies look like? So we decided to study this. We wanted to know the epitopes. We wanted to know whether it was a dominant epitope, whether They were neutralizing epitopes. And we also thought, well, if we have these antibodies, we can make a standard of it. And how did we go ahead? Well, in this case, a patient of mine, an ankylosing spondylitis patient, had a garage, and then suddenly his disease became active. He almost had to stop working, and then adalimumab came, which was a miracle for him. And for a couple of months, he was really happy, and then suddenly, again, the disease became active again. And we measured his blood, and there was no drug level, and there was a high titer of anti-drug antibodies. So we could explain to him what was going on, why this drug didn't work anymore. And he was happy because now he understood, now he knew what was going on, and this was important to him. And for us it was also good because we also now knew that we could treat him with another anti-TNF. So he was ready to give his blood for our research project, and we took some tubes blood of him. And from his blood, we isolated the white blood cells. And then we isolated the memory B cells. And then we tried to specifically sort these B cells with adalimumab to find the specific ones. So we have some enrichment, but not very much, because the frequency is low. And then we did a limited dilution, which is a trick known for many years from making hybridomas, which means that you have one single well per cell in a culture system. And now we have one B cell in a single culture system. And this single B cell is fed with cytokines and feeder cells that are irradiated, and a cytokine cocktail. And then we can make the single B cell grow out into a small clone. And this small clone then produces antibodies. And we can detect these antibodies with our assays. So we can pick the clones that are specifically making anti-drug antibodies. And in the old days, we had to make monoclonal antibodies by fusion with cancer cell line, but now it's not necessary anymore because we have DNA technology. So we can just sequence the positive clones. And having the sequence, we can use the sequence and put it into a factor, and then into a cell line, and then the cell line will produce the antibody for us. And then we can test the antibody for its reactivity. And so we did. And now we have more from different patients. We have 20 different monoclonal antibodies against adalimumab, but we also have monoclonal antibodies against infliximab and against natalizumab. So it's a general principle. We have even monoclonal antibodies against ACPA. We now have a trick that works. This is about the anti-adalimumab antibodies. So the interesting thing is we now have 20 monoclonal antibodies, and they all are different. So they all originate from different naive B cells. But then they have undergone selection and somatic hypermutation and have become IgG1 and IgG4, so T-cell dependent, high affinity. All these antibodies have a really high affinity against antibody against adalimumab. So a T-cell driven, very specific immune response against the drug. And then the question is, are these antibodies neutralizing? And to test this, we made another assay. And in this case, we took a cell line, an endothelial cell line. And this endothelial cell line stimulated with TNF produces IL-8. And if we then titrate in adalimumab or whatever anti-TNF in a concentration, the IL-8 production will get less because there's less TNF. We also have a reverse system with a V-high cell line, but this works. And then we tested the monoclonal antibodies. And in the first line, it's the cells stimulated with TNF, then we have IL-8 production. If we add in adalimumab or infliximab or any other anti-TNF, the TNF-induced IL-8 production is gone. But if we add one of our monoclonal antibodies, and in fact this is true for all the monoclonal antibodies, together with, in this case, adalimumab, the signal is completely restored. Adalimumab doesn't inhibit TNF anymore. And as a control, infliximab, which you could use any other anti-TNF, it's not affected by the monoclonal antibodies. And this is true for all 20 monoclonal antibodies. So they are all really specific. And they all are neutralizing. Is that a surprise? Am I telling a new story? No, I'm not. I'm just telling something that I think immunologists or people that worked in this field know for many, many years. I think John Isaacs, who worked on monoclonal antibodies already in 1990, wrote a paper on antiglobulin antibodies. Even human monoclonal antibodies have an idiotype that is unique. And because this idiotype is unique, it's recognized by the immune system of many patients as foreign and will induce an immune response. So the immune response is directed against the idiotype. And the idiotype is the part of the molecule, the unique part of the molecule that neutralizes TNF. So if the antibodies bind to the therapeutic antibody, TNF cannot be bound and can be active. That's simple. And this is true for, I think, antibodies against monoclonal antibodies in general. We've looked at anti-allotypic antibodies, but we cannot find them. So the dominant epitope seems to be the idiotype. And we now have more data, unpublished, that this is true for all the anti-TNF-based antibodies. And also in other circumstances like natalizumab, it's the same story. So it's a general principle of therapeutic monoclonal antibodies that they can induce an anti-idiotypic response. They don't have to. There are examples of monoclonal antibodies like herceptin or omalizumab that do not seem to induce an immune response. And there are also examples of many therapeutic antibodies of which we don't know. But if you do see an immune response, very often it's the anti-idiotypic immune response. So it brings us back to basic principles of treatment, to pharmacokinetics. What are we doing with our drugs? And I'm going to take you to the pharmacokinetics of infliximab. What do we do if we have a patient? Well, we give the patient an infusion of 3 milligrams per kilogram. And then we reach high levels of infliximab in the circulation. And we have the half-life of 3 weeks. But after 2 weeks, we give another infusion, and after 6 weeks, another infusion. And then we enter the 8-week interval. And in this 8-week interval, usually in patients not making antibodies, there will be measurable drug, 1-2 milligrams per liter. But what happens if you make antibodies? If you make antibodies, it's getting a battle between the immune system and the physician. The physician tries to put an antigen or drug, and the immune system makes antibodies. And because our treatments consist of a whole lot of monoclonal, so all the same protein, the amount is really important. So it's depending on how much antibody you can produce, whether or not you make a difference. If you make more antibodies than the physician gives drug to the patient, you will end up with a system where you have a lot of immune complexes, small immune complexes, and free anti-drug antibody. In many patients, the production of antibodies is less than you have drugs present. So in those patients, even though they make antibodies, the antibodies will complex, so you will lose a little bit of your drug, but there's still enough free drug present to do the job. So in the end, it's all about drug level. But the interesting thing is that there's a lot of variation. In some patients, 10% of the total immunoglobulins can be directed against the drug. And in this case, never ever the therapeutic protein will work. It will be complexed immediately. And in other patients, it's just a balance. And even in some patients, as we know from antibody formation against factor VIII, which is seen in hemophilia patients, around 30% of them make antibodies against factor VIII, and these patients bleed, so you have to continue treatment. In rheumatoid arthritis, we can stop a treatment if it doesn't work. They have to continue, and what you see is that if you continue for a long time, the immune system might shut off again, and we call it tolerance. This also occurs with biologicals. We don't know to what extent. Not as much as in hemophilia, but probably because we do not wait with ineffective treatment for 2 years, then we stop. One of the issues with immunogenicity is that there is not a lot of long-term data within the public domain. And even well, there was recently a paper of the FDA itself stating that when it looked back at the way they dealt with immunogenicity during the last 20 years, that they accepted insufficient methods to detect immunogenicity. Because most of the assays that were used, they didn't say exactly which products, but it's for more than 10 products, were all very drug sensitive. So they could not make a real statement. So this is a confession of the FDA afterwards. So limited data in the public domain. We did one study with long-term follow-up of around 300 patients treated with adalimumab. Rheumatoid arthritis patients, basically all patients we treat, so unselected. And in these patients, we follow drug levels and antibodies to adalimumab. And what we saw was that we could detect anti-drug antibodies with our standard assay in around 1/3 of the patient. Why is this interesting? Well, it means that it's something that happens in every rheumatology practice around the world. And in fact, I believe it happens not only in rheumatology, it happens in gastroenterology, it happens in neurology, it happens with many different biological treatments. But you will only see it when you look at it. Well, in which patients did it happen most? Well, especially in the patients not using methotrexate. So around 20% of our patients do not tolerate methotrexate and do not take it. We did an analysis published in the Annals of Rheumatic Disease where we looked at the relationship between the concentration of concomitant methotrexate and the frequency of anti-drug antibodies. And what we saw was that if you use monotherapy, the frequency is almost 50% in 3 years follow-up. If you use 5 or 10 milligrams, or 5 or 7.5 milligrams of methotrexate, which is a really low dose, you already see a tremendous difference. But if you use more methotrexate, you reduce the problem more. So the highest dose of methotrexate gives you the lowest number of anti-drug antibodies. And this is, yeah. In the end, what anti-drug antibodies do, they themselves do nothing. If you have an anti-drug antibody, so what? It's not a big deal. We have antibodies against many things. The only thing is that if you add the drug, they will affect the effective concentration that is still present in your system. So again, it's going to be about pharmacokinetics. In our cohort of adalimumab-treated patients, we decided to rank the patients according to the level of adalimumab in the system. And each point here in this graphic is 20 patients of our cohort. And on this X is the difference in DAS28 from time point 0 to time point 28 when the drug levels were measured. And what we see now is a drug efficacy curve. I think a basic curve we should know when we do a treatment. And what we see is that if there is no adalimumab in the system, no trough level, there is no effect. But we also see that the drug is very effective, because even if you have relatively low concentrations of the drug in your system, you have a powerful effect. We also see that here, with around 8-9 milligrams per milligram of adalimumab in your system, you reach a maximum effect. And then you see something interesting. We see that there's a large group of patients that has really high levels of adalimumab in their system, but these high levels of adalimumab do not provide us with an extra benefit. So you could say that this is a waste of money, because we spend a lot of drug achieving drug levels that are too high, only can give us side effects, maybe a higher infection risk, I don't know, but these higher levels do not offer us an increased benefit in the RA patients. And I think this is a graph we will have for all kinds of biologicals. And why do we have this graph? We have this graph because for some reason people think that biologicals should be used in a single dose. This is the dogma of biologicals. So people do dose-finding study using different dosages, and then the doses that has the maximum effect is chosen. Even though, as for adalimumab, it has been shown that for many patients, 20 milligrams might be enough. And this one single dose is then tested in a double-blind randomized clinical trial and put into a registry. And this system means that we have a fixed dose. But in fact, it means that we overtreat some patients in order to have enough drug in other patients. So it also means that if we can use this system by measuring the drug levels, and this is what we are currently now investigating, we're measuring the drug level at a half year of treatment. And if the drug level is really high, then we increase the interval. Then we go from 2 weeks to 3 weeks. And what does it benefit? Well, in general, nothing, because the drug level will remain within the range of maximum efficacy. However, it will save us a lot of drug. It will save us a lot of money, and we can use this money to treat other patients. And we also will, because we do this, we also will notice that in some patients, the drug is without an effective, not within an effective concentration, and we can consider changing the treatment. In the end, in our system, in anti-drug antibodies, patients without anti-drug antibodies do well. They reach our clinical remission. Patients that do have anti-drug antibodies measured with a standard system do not have a clinical benefit, do not reach our sustained remission goal. And so this is measured with a standard type of anti-drug antibodies assays. If you use the PIA system, so the system that disrupts immune complexes, and we published this also in the Annals of Rheumatic Disease, I think this year, you will see that the majority of patients make antibodies. However, in a vast group of these patients, the amount of antibodies against the drug produced is not so much that it clears all the therapeutic drug to become ineffective. So you don't notice it. You still have an effective concentration despite the fact that you make antibodies, because it's less. What about etanercept? For etanercept, we did similar studies. And basically, the story of etanercept is not much different than from adalimumab or infliximab. It's also about pharmacokinetics. We could see that if we looked at the drug level, patients not doing well, patients with the lower levels of etanercept had less improvement of disease activity than patients with the high levels of etanercept. There's a remarkable difference between etanercept and the therapeutic antibodies, and this difference is the half-life. For some reason, etanercept has a half-life of only 3 days, and probably this is linked to the fact that it's not recycled by the FcRn receptors that normally take care of antibodies, and they they recirculate the therapeutic antibodies within the circulation, and probably etanercept doesn't survive this system, and therefore, in general, despite the fact that you give 50 milligrams every week, so a higher dose than the 40 of adalimumab, your drug levels are much lower. We did not find antibodies against etanercept, although I should say that within the label it stated that there are antibodies. But again, I should remind you that 10 years ago, the way we thought about measuring these anti-drug antibodies was really different than we do now. And there's also a paper an abstract at the ACR published that from Janssen, so a competitive industry, they also found antibodies against etanercept. But the details of the methods have not been published. In our hands, with our assays, we have not detected anti-drug antibodies against etanercept. Does it mean that they are not there? Well, I don't know, because it's very difficult to show that something isn't there. We do not see the variation in pharmacokinetics, so we do not see those patients without having any drug level at all, indicating that it not affects pharmacokinetics of infliximab in the same way as it affects, as anti-drug antibodies affect therapeutic antibodies. And the reason, we believe, is that the basic difference between etanercept and therapeutic antibodies is that it's not an antibody. And the anti-drug antibodies, in case of therapeutic antibodies, and this is the case for adalimumab, infliximab, but also for natalizumab and many, many other therapeutic antibodies, is the idiotype, the unique sequence of the molecule that is new to the immune system. And therefore, it's more or less normal to make antibodies against it. Etanercept also has a weak spot, and that is the region where the Fc tail molecule is linked to the receptor. The receptor, of course, is known to the body, so you don't make antibodies. Lanacept, the sister molecule using the other TNF receptor, was very immunogenic, and it was because in the linking region there were epitopes. But for some reason, etanercept doesn't seem to have an immunodominant epitope within this region, as far as I know. So it should not. I'm open to hear from somebody a different statement, but this is as far as I know. So why is this story clinically important? Is it important because it differentiates Enbrel from therapeutic antibodies or for commercial reasons? No, I don't think so. This is not the reason why I'm here. The reason why I'm here is because it's important for rheumatologists to treat patients. If you have NICE criteria, and I believe you use it in Argentina, the NICE criteria, is that correct? Then there's something strange going on, because it means that if you have patients in which immunogenicity causes anti-TNF to fail, you cannot use anti-TNF anymore. And from our standpoint, this is not logical, because we hypothesize that there are different types of non-responders. In patients who have high levels of anti-TNF and then fail, of course, it's logical not to try another anti-TNF. However, if immunogenicity is the reason, it means that you're not an anti-TNF failure, but you failed a specific molecule, because the specific molecule was neutralized by anti-drug antibodies. To underscore this hypothesis, we said, well, we're going to look at our patients in the etanercept cohort, and we also did it in the adalimumab cohort. It has the same story. And we're going to look at naive patients, or patients treated for the first time, and patients that switched from one TNF to another TNF. And then we looked of those patients that were switching from one TNF to another TNF, whether or not they had anti-drug antibodies. And we hypothesized that if they had anti-drug antibodies, that the clinical response to etanercept would be similar as the naive patients. However, that if immunogenicity was not the problem, okay, then it's correct. Then you have patients that have probably adequate drug levels, anti-TNF levels, that do not respond to the mechanism. So you should look for a different mechanism. And when we analyzed this, indeed, it confirmed our hypothesis. The improvement of naive patients on Enbrel was 2.1. Switches from anti-TNF monoclonal antibodies without having detectable immunogenicity, we didn't look at drug levels then, have an improvement that is remarkably less. But patients who have immunogenicity associated with their failure of an anti-TNF antibody, they have an improvement that is similar to the naive patients. So making no sense in not giving patients a second chance to an anti-TNF if immunogenicity is the problem. So by investigating this, and I think by investigating our treatment with therapeutic drug monitoring, basically I advocate to measure the drug level in your patients just once, for example, after 6 months of treatment, just to know whether your drug is within the therapeutic range. And if it's really low, too low, or absent, then probably the patient's making antibodies. The other explanation would be that the patient is not taking the drug, but usually our patients with effective medication are really compliant. And in that case, you can switch treatment to another treatment with the same mechanism. And I think from a financial point of view, we could use therapeutic drug monitoring to attack overdosing and to attack money. Because if we overdose patients, we throw away the drug and we do not use it for other patients. So by identifying the ones that that have so high levels of the drug that it's unnecessary to have the standard dosing regime, and we can do an increased dosing interval, you will gain, we probably can gain a lot of money that we can use for the treatment of other patients. So we can have more patients that benefit from biologicals. So in conclusion, immunogenicity to therapeutic antibodies is associated with altered pharmacokinetics. It's influenced by several factors. Methotrexate is an important one. If this is something you remember, I'm also happy. But there are also other factors, like genetic factors and like dosing. I thank you for your attention. Again, a lot of people worked on this. Most important of all is Lucien, but also a lot of other people in the lab and in the clinic are dedicated to doing this. I thank you for your attention, and I'm happy to answer any questions if you want.
Thank you very much for this interesting conference. If we have questions, yes.
Thank you. Maybe you're familiar with algorithm that has been proposed very recently by a Dutch group in the last segment of last year. This algorithm is proposed for non-responders to anti-TNF agents, and is based on amount of circulating drug plus immunogenicity. Therefore, the consequence is that you have 4 groups based on these 2 variables. The only group that, in which the conclusion is, or the suggestion is to change to a different family of biologics is, of course, the one of non-responders that have adequate levels of drug and no immunogenicity. That's definite, doesn't work. So go to rituximab or whatever.
Yeah.
Okay. And last week, in the same ARD, this proposal, this algorithm was criticized for being too ambitious and unnecessary and with no practical consequences so far. Are you familiar with this story?
Yeah, I think I've seen the letter. I think the review paper and the algorithm is from a France group of Xavier Mariette. And I think the response letter is of Alfred de Broeder from Nijmegen. So I'm familiar, yes.
Yeah. What is your opinion on this algorithm?
Yeah, I think basically, what the letter said was that there's still a lot of room for research. And I fully agree. So we have to have more information, but I think it will be rewarding if we pursue this line. In principle, the first thing we have to learn and to check is if we do a very expensive treatment, whether the drug is within the concentration we think it's effective. This is a very simple question, and I think this is a question we could ask probably for many patients treated in many diseases with many biologicals. In natalizumab, same story. Some patients make a lot of antibodies, they clear the drug. And then you don't have any efficacy. It's very clear shown in a nice study. But many other patients have too high levels of natalizumab. And also there you can reduce the overdosing and switch the treatment in those patients that do not have any effective drug level at all. So I think the rationale for looking at biologicals in this way is there. And I think the power that will enforce it will be the money, because it will allow us to take some of the money back we now spend on biologicals that is unnecessary. And because money has become a problem, I think we have been spoiled for many years, but then suddenly in Europe a crisis came and money seemed to be non-existing anymore. So now money is a real issue. In our hospital the budget is fixed. We cannot use more money, so we have to find ways to use the same money in a smarter way. And it means that if we spend money on drugs by overdosing, it's not useful. So I think to answer your question, I think we will go there. We will get algorithms. We have to prove it. We have to do trials. We have to find out how. There's still a lot of things uncertain, but the money will drive us.
Another collateral question. I haven't seen Paul Peter Tack's name in the list. And he wrote, I understand, if I remember properly, a lot of papers on adalimumab immunogenicity,
no, so
including one expressing that the patients with immunogenicity to adalimumab had an increased frequency of thromboembolic events.
I think all these papers, Paul Peter Tack, I was the last author of those papers, and he participated by some patients. I didn't talk about side effects, also because one of the companies was having legal issues with talking about immunogenicity, so I decided not to talk about it. Although as an academic researcher I would like to talk about it, but it's not possible.
Dr. Wolbink, thank you for your nice presentation. I also enjoyed them very much. I think it's really a very practical approach, and I'd like to make a point and a question. I think probably these should really be part of our current clinical practice in a systematic way. So maybe you'd like to comment on that. And I have a very specific question. If a patient has, for instance, a low trough level of infliximab concentration, but there are no drug antibodies that are detectable by a reliable method. Is there some sort of mechanistic way to explain this, that the antibodies may still be there, but you just can't detect them?
Yeah, I think in general, I think the major factor with therapeutic antibodies and pharmacokinetics is anti-drug antibodies. And many of the assays suffer from drug interference. So if you have low levels of infliximab, you frequently do not measure those antibodies that are in complex. And, but they still are the explanation. So I agree.
But is there any, I mean, basically if we have a low trough level, then and we have the antibodies, the solution will not be to increase the dose or to decrease the spacing between administrations. So is there any suggestion?
That is not so easy. That is not so easy. So one of the complicating things is that there's a lot of variation in how much antibodies we make against the drugs. And we don't know yet what controls it. So I would use a practical approach. And the practical approach would be, well, there is some drug level. And a case for infliximab, I think the 3 milligrams per kilogram is somewhat low dosed. So as we do, in general, we increase in some patients the frequency of infliximab. But you could also say, well, if it's going to be very costly, I might choose a different anti-TNF with which I can reach optimal trough levels in an easier way.
Thank you.
Okay.
Thank you. I have another question. How costly is to check biologic drugs, and how often do you suggest to do that, and whether you have any study showing that checking biologic drug levels is cost effective?
Yeah, I think basically it should. If we think that this is going to be something that is going to belong to our treatment algorithms, whether or not it's now or in the future, it's a simple as ELISA. It should be cheap. And I think nowadays it's only availability of the ELISAs. You can send me an email and then I can give you a kit to make your own assay. And there are some companies, I think Progenica and some other companies that in general the issue with these tests is rather that it's too cheap and therefore not profitable for many companies to put a lot of effort in it, than that it's too expensive. And when should we test? I don't know. I have the gut feeling that nowadays maybe after a half year of treatment, testing it once would be okay. In case you find extraordinary clinical responses, non-response or strange side effects, then I also would be curious by looking at it.
Enrique, real quick.
Yes, Roger.
Is there the right time to do the test, or you do it every time there's the next dose?
Yeah, so I think the only very crucial point is that we're talking about trough level. So in order to have information on it, we should take the drug just before the next infusion. You have a trough level. If you just randomly take your sample from your patient, you will have a huge variation in levels, and we do not have the information to interpret it. So that's the important thing. Take a trough level.
Okay. If there are no more questions, thank you very much for this very nice conference.